you take his permission. Okay.
You're sure you can start, no problem.
Sir, I am giving YouTube, then I am giving the broadcasting. Just
Okay, okay, no problem.
Starting the YouTube share only. Broadcast you start once the program starts at.
Yeah. I have started YouTube sharing only.
Don't start the broadcast. Broadcast starts at 7.
Yeah.
Nice to see Dr. Kapil.
Hi.
Hi, sir. Hi. Good. How are you?
I'm fine. Now recording started, no?
Yes, but broadcast I have not given.
Broadcast you have not given. Okay.
No, after 4 minutes I give the broadcast. It's 6:56.
Correct.
Sanjay Das sir has not joined. Andrew, please call Sanjay Das. Dr. Sanjay Das. He has not joined.
Okay.
Sanjay has joined or not?
No, sir.
No, I have talked to him. He will join.
Right now he's joined. Sanjay sir, good evening.
Sir is muted. Unmute, sir.
Oh.
Sir, good evening, sir.
Sir, unmute করুন. Good evening.
Those who are muted, না তাদেরকে এরকম একটা like unmute please. Because they cannot listen.
এটা দারুণ idea, sir.
Show some instruction in this way.
Okay,
that's
okay.
nice.
Yeah.
Nice.
Sanjay sir, just say hello so I can check your voice.
Hello, Sonendu.
Hi.
Sir, namaskar from Kolkata.
Namaskar.
Nice to see you again, sir. Now it's nice to see you again.
Yeah.
Just 3 minutes left.
Okay.
Sastha sir,
Yes.
can I give the broadcast now? Only 2 minutes left.
Once we start, we'll switch on the broadcast.
Okay.
No, exactly at 7 o'clock dot you start.
Yeah. Andrew, you start.
Yeah.
You start, then you give it to Dr. Kapil. So Dr. Kapil will introduce Dr. Mohapatra, and then it's Dr. Mohapatra. And lastly, Mr. Chakraborty will give the vote of thanks to.
Yes. I already.
Yes, that's the way. Right.
सर कितना दिन ओडिशा में आने नहीं देंगे बताइए तो.
बस मेरा तो सदियों हो गया नहीं गया.
মদনদা ভালো মদনদা কিরকম আছে?
ভালো আছে তো?
হ্যাঁ, আপনি কি আগরতলা ছেড়ে দিয়েছেন নাকি?
না, আমি অন পেপার আছি, অন পেপার।
আচ্ছা, ওই কথাটা তপন সরকার আমাকে বলেছে।
রিসেন্টলি ওদের একটা ক্রাইসিস হয়েছে, আমাকে যেতে বাধ্য হয়েছে।
আচ্ছা।
1 minute to go.
1 minute to go.
Yeah, one.
Andrew, be ready, huh?
Yes.
Video.
Sir, I'm giving broadcasting.
Yes, you can start. Yes.
Andrew, broadcasting started.
Broadcast?
Yeah.
Start. So, wonderful evening to all.
Just a minute. Let's join the participants. Just broadcast started. Yes.
Okay, ready to go.
Okay. Ready, sir?
Yeah.
Sir, wishing you a wonderful evening and a warm welcome to all the eminent delegates to the 6th episode of Odisha Journal of Orthopedics and Trauma PG seminar webinar along with an academic initiative from WOHARD. Sir, today we have a very interesting focus topic which will be revealed by none other than our WOHARD medical head, Dr. Kapil Dev Mehta. And today I am also very happy to announce our WOHARD Vice President, Dr. Gautam Chakravarti, is also present among us to share his views with us. So before handing over to Dr. Kapil, I wish to mention a quote by George Bernard Shaw, which goes as that the single biggest problem in communication is the illusion that it has taken place. I hope that already everybody can guess what the topic could be. So with this, I invite Dr. Kapil to come.
Thank you. Thank you. Thank you.
Dr. Kapil, please.
Thank you. Very good evening to all of you. I am Dr. Kapil Dev Mehta from WOHARD. And on the behalf of WOHARD, I welcome all the faculty and all the delegates attending this symposium. So today we have a very interesting topic. It is about communication skills and professionalism in clinical practice. And for this symposium, I would like to introduce the coordinator for this symposium, Dr. Nirmal Chand Mohapatra. He's professor. He's working as professor and HOD in orthopedics in SCB Medical College, Cuttack, and also working as director, Regional Spine Injury Center, Cuttack. Dr. Mohapatra is a clinician, is a researcher, and also all women into one. He has all the qualities. He's a fellow of Johnson & Johnson India Orthopedic Association, also a senior fellow of British Indian Orthopedic Society, UK, the Rotary Foundation Scholar, and past senior research fellow at CSIR. As I told you, he's a prolific researcher and has done a lot of research. He's also editor-in-chief of Odisha Journal of Orthopedic and Trauma. Sir, it's an honor for us to have you today for this webinar. And now for further proceedings, I hand over to you.
Thank you, Dr. Kapil. And welcome to you all. Good evening. I welcome you all to the faculty, panelists, and participants to this webinar in the evening. So the burning question is today is, do we need to communicate with patients with empathy, or do we boss around like the second God? That's the biggest question now today. So we have eminent speakers to be talking about this. Before I introduce, let me introduce our faculties first. So we have with us Dr. M.M. Roy. He's a fantastic gentleman. I am here to see a second person in orthopedic sphere like him, and with a 35-year experience. What I have heard, he's such a fine gentleman. If a patient comes to him once, he never goes to back any other orthopedic surgeons in West Bengal. So let's see what is his magic wand, what is the his geniusness he will be imparting to us. We'll be talking on effective communication with the patients and family. Now we have Dr. John Ebenezer, who is a good Samaritan and works with a missionary jail. All this lockdown period, he was busy helping people in the Karnataka, which was one of the hotbed of this COVID. So if you don't know Dr. Ebenezer, you are not an orthopedic surgeon. If you are all the young people, young doctors must have read his book. Without reading, they cannot be doctors. Sashwata is seeing smiling. So Dr. Ebenezer has amassed almost all degrees. There's nothing left in orthopedics. He's a Padma Shri, 2 National Research Award winner, like BC Roy National Award and Silver Jubilee Research Award of NCI. He has more than 280 awards nationally and internationally. He has won, and he has won 8 Guinness Book of World Records, and maybe the only orthopedic surgeon. He's a prolific writer. He has written more than 53 books in a single year. You can imagine what is his zeal with his writing and publishing the things. Okay, so he has published he has presented more than 300 international, national talks and learned many free. I told you he's almost a missionary zeal. He's a good Samaritan. He has special quality with geriatric peoples. We know we always not take the voice of senior people very seriously. So he will be talking us how to deal with our elder patients who are a special group. Now we have Dr. P.V. Vijayaraghavan, another fantastic gentleman who is always smiling. You see, you will never be able to see him under stress. So he's a Dean, Education and Director, Academic Administration, Professor of Orthopedics in Sri Ramchandra University. And I know him for maybe last more than a decade. And most important thing is, he is very actively involved in teachers' education by MCI. And he is one of the played pivotal role in this academic, in the change of curriculum of MCI to bringing this affective domain like at home and then how to communication, etc. under for this new PG curriculum. So he is a big man behind. We'll have a good experience from him. And Sanjay Das, you know, he is always full of empathy. He is a man, he was director of NIRTA. He is the man who fitted all the prosthesis and orthosis, all this to the amputees and etc. So he has fantastic experience rehabilitation and dealing people with disabilities, patients with disabilities. Even he has got award in doing his good job in Afghanistan from late our President Abul Kalam Azad. And Swarnandev, he does not need an introduction. He has been so busy doing webinars. I'm sure he will be getting a Guinness Book of World Record. Almost every day, 3-4 webinars, really busy. So we'll have some experience from him. Now coming to interest the topics, there was a time when doctors were the second god. Even both in rural and urban setup, people alike revered the medical personnel and blindly trusted them with the lives of their loved ones. Alas, the time has changed. The doctor has become the bringers of death. Dr. Bana Jalad, this is the topic now. There has been a sea change of attitude of people towards doctors. So I remember one of my seniors, a very good, fantastic orator in the field of cardiology, giving a lecture in our auditorium. He told, you see, doctors are even more dangerous than Jamraj, because Jamraj will take your life only, but the doctor will not only take your life, along with that, your money. So that is the attitude what has become changed, attached with the doctors by the public in recent times. So according to an ongoing ICMR study, more than 75% of doctors have seen violence at work, maybe physical, maybe verbal. Every day you see national newspapers and doctors being abused, manhandled, beaten, even killed by the patient's relatives. The highest number of violent incidents, close to 50%, occurs in ICU and almost 70% caused by relative of patients. This is not limited to India. This is all over in Southeastern Asia, like Nepal, Pakistan, Sri Lanka, in China, Turkey. And even in a study in United States, America, more than 50% of health personnel are abused physically by sometimes during their curriculum career by the patients. So the problem is multifactorial in origin. The most important is a trust deficit. Earlier, when there used to be only one medical officer for an entire village or a small district, people trust in the doctor remained high. The doctor was regarded as part of the local community and was integral to the health and well-being of the social unit. Even this is the reason why I decided to be a doctor. Actually, I have seen the amount of respect, prestige given to a rural doctor in my rural area. So that is a paramount force behind me being a doctor. With commercialization of health and rise of corporate hospitals, the mentality of physicians has changed from from a charitable to a lucrative one, so also the people's perception of doctors. Welfare model of government hospitals where an average doctor sees more than 300 patients, it is logical the quality of care gets compromised with other lack of infrastructure. All government setup and even in some private sector, there is also lack of security. And Indian media also has played a major role in demonizing doctors in the objective of selling news. So currently, medical practice is at crossroads. So there are so many questions. Are we communicating enough with the patients? Are we lending them an ear enough? Are we keeping them waiting long? Are we treating the elder people with special care they need? Are we making them terrified about their conditions? Are you showing empathy for suffering and sympathy in financial dealings with them? Are we putting an effective management strategy and damage control plan in our practice? All this need to be answered today with our eminent speakers. So medical curriculum, Indian schools are excellent in imparting medical training to their students. However, teaching to be empathetic towards patients is seriously lacking. Young doctors fresh out of medical school are often not empathetic enough with patients and attendants, leading to a sense of permissive neglect in case of the patients. This often triggers the violent assaults. The importance of teaching empathy to budding doctors cannot be stressed enough. Proper and effective communication with the patient and the attendants is an art and should be taught to all the young doctors. It is not like that we'll tell them, you are welcome to the jungle, be ready to get hurt, and it is the price you pay for being a doctor. So MCI has woken up to this reality and taking steps to mend this defect in curriculum. So our curriculum, there is affective domain where all these communication skills, how to deal with the patients, how to deliver bad news, all this have been incorporated to be taught to our young doctors. So William Osler famously said, the good physician treats the disease, the great physician treats the patient who has the disease. Let us hope we learn from this webinar how to deal with our patients, how to communicate with them for a proper outcome so that we get a good repute in society and get out the good outcome. Now I invite our eminent speaker, Dr. M.M. Roy, to speak on effective communication with the patients, after which Dr. Ebenezer will be speaking. We will give ample time to our panelists to air their views, and if necessary, we can stretch the time from 1 hour to another half an hour to 1 hour if the time permits. Thank you. Now I request Dr. Roy to come present his topics.
I will share the screen. I'm going to share the screen. Is it visible there in your screen?
Yes, sir. Yes, sir.
Okay, and I'm audible also?
Yes, sir.
Okay. Good evening, Nirmal, Sanjay, others, and Dr. Devinger, and all that, and Shishan. So, and present all the dignitaries present here. I'm very much grateful to you all for getting this opportunity. So my topic, as Nirmal said, that effective communication. And thing is that he has said about 75% of the doctors have seen violence. So that is a terrific thing, isn't it? So, and just a minute, not slide. Okay, to the patient, I'm just going to start. My talk will be mainly on the office visit. To the patient, who is the best doctor? That is a great thing, or the big issue to the patient. They always think that I should choose such a doctor who will be the best to me. Now, what are the criteria of a best doctor? That is the ABC quality. A doctor who has the ABC quality. A means available or not. B, his behavior or good communication is there, or who is professionally competent or not. So these three qualities are very, very important to our patient. And especially we have some, as Nirmal was explaining in the beginning, this communication. If you do not have effective communication, really it will be messy and lot of problem will arise in our clinical practice. You know, doctors are, patients are, doctor dependency, it has been increased. Patients have become more doctor dependent. It was not before 50 years ago. But for a minor problem in nowadays, the patients, they consult the doctors. And it is also a fact that about 2 lakh consultations are done in one by any doctor, busy doctor, and 10 to 15 lakhs family members he has to meet in his lifetime in clinical practice. If that be the reality, why should it not be the state of the art? Our consultation, our communication with the patient and their family member. Why should it not be a state of the art? You know, in our medical curriculum, what we learn, there is some medical technical knowledge, how to examine the patient physically, and some stuff, there is the medical problem solving stuff, but communication is missing from the list. We are a little bit poor, I should say, in professionalism because it is not in our curriculum or syllabus of medicine. Recently, MCI has introduced a little bit of thing, but not to that extent what it should be. So communication in clinical practice, I will try to highlight the most of the things about what to do and how to tackle our patients in office visit. But there are certain things in clinic when we are making round in the indoor patients or when we are tackling the patients in operation theaters and others, but highlighting mainly in the office visit. Just a minute. Disturbing. Our professional goal is not only to treat human being, but also to get more and more satisfied patients. And to get such more satisfied patients, good relationship with the patients is absolutely necessary. And to have good relationship, we need to have good communication skill, helping attitude, and good intentions. Mind that it is carefully judged by your patient. Research confirms that the doctor-patient relationship is the best predictor of whether the patient will follow the doctor's instruction and advice. If your relation is not good, they will simply ignore your advice. They will go to another doctor. Probably you could not convince your patient that that should be the ideal treatment or that was the real diagnosis. So they will have a lot of different. So you communicate properly and show your honesty, show your good intention, and then they will believe you. And relationship with the patient starts when you start consultation. Now, what is consultation? Consultation is nothing but meeting between two experts, doctor on one side and the patient on the other side. Doctor is an expert of technical things and patient is also an expert in the experience of his illness. He knows better how the myocardial infarction pain, how painful it is, what is the intensity, everything he knows better than the doctor, because the doctor had not had that experience, but the patient had. If they had the opportunity to write a book on what is the experience of the patient, they could be the better, I think, the writer. So do not underestimate the patient. Doctors attire. It is highly debated issue in the world, but this innocent lady is confused totally with the appearance of the doctors. So, and a dancer without proper stage and costume and makeup, she cannot perform. So what is required? A proper stage, proper costume, and etc. And many studies support that white coat as preferred by patients, and white color is chosen to associate doctors for purity and cleanliness. It is almost acceptable in the world that a doctor, the formal dress of a white coat, usually in that. Many corporate hospitals have their different colors and all, but most preferred, it has been, there's a study that most of the patients, they support that white coat as the doctor's attire. And physical appearance of a doctor, it is not for attraction, but to gain the confidence of the patient. A formal dress with white coat, proper hairstyle, proper shoes, like this hairstyle, these shoes, all are important and they are very much acceptable to the patient. Your consultation room has got some importance. A quiet environment, clean room, clean examination couch, proper sitting arrangement for the patient and the doctor. They are all important for a good consultation and to have good relations with the patient. Otherwise, patient may not have faith on you or may take it otherwise. Anybody may be your patient, starting from a political person to a sports personality or the film star or Amjanta, the common people. Anybody might be your patient. So you need to have some attitude, a universal approach for all of them. For the political person or the Amjanta is a different one. It's not that. So you will develop such a system or such an approach. It is applicable to anybody in the world. That universal professional approach. That universal approach is there, but there should be different consultation style. Approach should be universal, but your consultation style may be different depending on the nature of the patient and illness. How most of the consultation is like that, and a friendly environment is created where the patient is relaxed, he's comfortable, and he or she can disclose his or her illness properly. But there are some situations doctor is submissive and patient takes the upper hand. For example, a patient is a chronic sufferer or where the outcome is very poor. So in that situation, whatever doctor has very limited things to do for the betterment of the patient. So whatever patient says, he agrees, he becomes submissive, and he is to listen to the patient and act accordingly. This is the just opposite. Doctor takes upper hand and patient submissive. In which situation? A doctor is not, the patient is not taking care of your advice. He's not doing the exercises. He's damaging the plaster. He's walking before you have advised. So in that situation, you take the upper hand and you can. Next, mind that the next consultation, before you go for the next patient, clean your mind of the last patient as you wash your hands to prepare for the next. Do not think of the previous patient while examining your present patient. Think about, at the same time, think about your timing because your next patient is waiting outside. Your posture and body language is very, very important. Definitely your patient will not like it. But the simple gesture, such as little leaning forward, it has been found, and this will make the patient relax. He will or she will feel comfortable, and she will be very free to disclose his or her illness. And patient will be definitely satisfied. That's a study. Doctors do more talking than listening. A new study published in JAMA found that 72% of the doctors interrupted the patient's opening statement after an average of 23 seconds. And patients who were allowed to state their concerns without interruption used only an average of 6 more seconds. That means 29 seconds to 30 seconds is enough for opening statement of the patients. But we doctors are little bit impatient. We do not allow, yes, next, what's happened next? You go on like that. That should not be the attitude of the doctor. Doctors often ignore the patient's emotional health. A study of 21 doctors in an university-based clinic found that when the patient dropped emotional clues or talked openly about emotion, the doctor seldom acknowledged their feelings. Instead, the conversation was directed back to technical talk. It happens sometimes. The patient is immediately when comes to you, he starts that my father died recently yesterday, and then I fell down, then it happened, and go on about the father, expert father. You may be, you may not like it, but thing is that it is the patient's emotion. He will definitely, please allow them to talk freely, because that feelings or that emotion has got some value with the patient. You should acknowledge. In a, there's a study also, in a videotaped study of 171 office visits, doctors who encouraged patients to talk about psychosocial issues like such as the family and job had more satisfied patients, and visits were only an average of 2 minutes longer. They will take 2 minutes more time, but they can express their psychosocial, their whatever their feelings, they can disclose that, and patient will be satisfied if you allow them to speak in that issue. In this way, if we acknowledge their feelings with our facial expression, yes, I acknowledge your sorrows and whatever has happened. I listened it, and really, I'm also sorry for that. So that should be the expression and acknowledgement. That's a great man, as Nirmal was saying, that William Osler has a lot of observations. He said, always listen to the patient. They might be telling you the diagnosis. You go on, let the patient talk, tell them whatever they have. And there are some clues, and you may get the clues for certain points for your diagnosis. So listen fast, listen second, and give importance of the patient's statement. Usually for a consultation, it takes about 8 minutes time. It may be less than that. For a fracture call is how much time you like to take? Only 1 minute or less than that. But thing is that there are certain things on an average, it will take 8 minutes. Avoid frequent interruption of the patient's opening statement. Usually for the opening statement, it takes about 30 seconds. There is a standard examination style, taking permission of the patient, exposure, requirements of the body parts carefully, extra sheet to cover the limbs and trunk, female attendant in case of female patient, and avoid unnecessary touching of the patient. There are many patients who do not like it. Maybe a child, but her privacy is important. So we should take care of that. There are certain do's and don'ts on the part of the doctor. Use of mobile phone while in consultation with the patient. It might be, there might be some urgent call, emergency call, but with formal permission. May I have the call? This is a courtesy. And if you don't do so, the patient will have an impression, probably the doctor is ignoring me. Entertaining guests, friends, medical representative in your clinic. They're all important, I know. But thing is that they should have a separate time. Even if emergency, you keep certain medical representative, they will definitely give you a lot of information which you do not know. They will come with the newer things. But thing is that you make a separate time for them. So they will be happy and you will be in a mood to listen to those and you go through that. So have the separate appointment for them. That is my request. Eating, drinking, smoking, strictly not in front of the patient. They will have another impression that my doctor is interested in that thing, not with me, my illness. Patient does not cooperate always. Very often it happens so patient may be small, maybe they may come from the village or rural areas. So a little smile might help. So it is said that 17 muscles to smile and 43 muscles to frown. So if that be the reality, so why should we not smile to address a problem? Better not to do like this. Your patient does not like this apathetic look of a doctor. At least when you are in front of the patient or you are in consultation, your first thing will be, my patient is the only thing in the world and I should concentrate on him. I should show my face that I am for him. My confident look, my smart appearance will help. Otherwise, patient will not have the faith on the doctor, treating doctor. Doctors underestimate the amount of information patients want and overestimate how much they actually give. In one study of 20-minute office visit, doctors spent about 1 minute per visit informing the patients. But he believed they were spending 9 minutes per visit doing so. So usually it happens so. If I spend more time, but I think I have spent a lot of time, but it should give much more time for the round for consultation or the for any talk, any around, any discussions with the patient, give more time. According to a survey published in the Archives of Internal Medicine, 1 in 3 doctors do not always inform patients of abnormal test results, especially if the results are mildly abnormal. As you know, hemoglobin percent 12.9, if it is so, patient will come and will ask you, sir, I have seen it is 14.5, it is 12.9, so how should I survive? That might be a question, but you should explain that how much it is dangerous for him, how much it is, whether it will help or not. This simple explanation will help a lot. Otherwise, patient will find another doctor to solve his problem or to get his answer of this question. Doctors who cannot communicate properly are more likely to end up in the court. In an analysis of 45 malpractice cases found that many of the doctors being sued delivered information poorly and devalued the patient's views. Once again, the lack of communication. They could not explain, they could not show what are the procedures they were going to do, what they will do, how the operation will be done. All these explanations should be given beforehand. That's a fascinating study of the time perception found that when doctors in sitting position, doctors in standing position, when doctors sat down during an office visit, The patients always thought the visit was longer than when the doctors remained standing, even though the length of the both visits was exactly the same. For them, both 1 minute if it is 1 minute, but if you are standing position, the patient will have an impression doctor is in a hurry. He is not in a mood to listen to my problem. So, but if you sit and make the patient sit and you just explain this, in less than that time, she will be satisfied. Table acts as a barrier between the doctor and the patient. Here the table, and this should be the sitting arrangement of the of your clinic. The doctor, the patient will be closer to you. The patient, the table is not acting as a barrier between the doctor and the patient. And but this is not working with the COVID situation, of course. There is a separate issue, but it's a non-COVID situation. That should be the arrangement. The doctor, patient, and the relations in front. This is, I think, more comfortable the patient will feel as it is. And special consideration for elderly. Dr. Avenger sir will tell you a lot of things. He has a lot of observations and experience, and he's a very learned person, all of you know, and will learn from him in this aspect. Anyway, how you ask question, how you explain, how you set examples that patient what you will do for the patient. Suppose you are going to operate a patient, you will have to take the help of the X-ray. X-ray, this is the thing that was done previously. Your thing is that broken here with the showing an X-ray or the bones. So a proper explanation that what you are going to do and what will happen, and patient will understand. Until the patient understands well, he will not let the patient allowed to go. Not the patient, even his family members even. Because after the patient, you have explained everything to the patient, but his close relatives will come to you once again. So in that situation, always call the patient's near relatives, and you explain it properly when they will be convinced, and then you leave the consultation. It is also a fact, patients are not always perfect. In one survey, doctors rated that 15% of the patients are difficult, crooks, or turkeys. Researchers have identified some common characters of these patients. They are hard to manage. They do not trust or agree with the doctors, present too many problems for one visit, and do not follow the instruction. They are demanding and controlling. And nowadays, you will see they will enter to your clinic with a lot of downloaded message from the net with a lot of things, and they will start explaining everything, why this happens, why that has happened, it is shown there in the net, and showed what has happened to me. So what can be done? Once again, you maintain good relations. Do not argue. Do not keep your temperament should be cool, and tactfully you avoid all questions whatever he asks. You might say that my knowledge goes up to this. You can search any other books or any other consultants even, but thing is that it is the knowledge till date in the world. Peer criticism. Do not criticize your colleague. That is very, very important. Sometimes the patient will pose such a thing that they will ask you, tell me whether the first consultant was wrong in his my treatment. You just, then your stand will be that I'm not the judge. I was not in that situation. I do not know how it happened, why did it happen, but I can say that at this moment, you should do such and such things. The consulting physician should carefully avoid coming to a conclusion without knowing the facts. Obviously, a thorough review of the medical records is mandatory. Without jump, do not jump. To see what has happened. Patient may tell you that what has happened, tell me. And without seeing the records, you do not come to a decision or do not go for the conclusion that you will have to go to further operations or like that. Communication among the team members must be very clear and complete. Faulty communication can occur in a variety of settings. For example, a patient may be jeopardized when the referring doctor provides too little information to a consultant or when nurse-to-nurse communication lacks clinical data. Among the team members, the communication should be. For example, you have in the evening, you have asked your nurse that our patient will be operated next morning, but the nurse did not, but the communication was not properly done. And the morning, she has allowed the patient to have breakfast and the operation was cancelled. This simple thing happens. So proper and complete instruction should be given. And for one more example, you see, this morning it has happened in Calcutta. The one patient was admitted in one hospital, critically ill, and the patient died last night. And when inquiry, the patient relations was informed the patient is okay, but patient expired. But while the patient came, when patient's relations came to see his close relations, he found that one dead body is going to the post-mortem room, and he could identify that patient is his relations. Naturally, you just imagine what will happen. There was violence, there was a lot of unsatisfaction, there was a chaos. Media people came, and that was a news today. So that should not happen. It is simply lack of communication, because communication, it should be communicated as soon as the death occurred. After that, patients they should be communicated over phone and all. That is mandatory. Doctors often blame patients when communication breaks down, but researchers have found that many doctors have shaky interviewing skill. So not only the patients are to be blamed, but the doctors has also a little difficulties, particularly the interviewing skill. So communication skill is a basic clinical skill. Communication is a series of learned skills, not a personality trait. Anyone who wants to learn can do so. It is not difficult one, but it is, if you practice it, it will happen. And what is the charm of good communication? Doctors with good communication skill identify patients' problems more accurately. Patients are more satisfied with their care and can better understand their problems, investigations, and treatment options. Patients are more likely to adhere to treatment and to follow advice on behavior change. But for that, the professional excellence, to maintain the professional excellence, it is really a difficult job, I tell you, but it is possible. Always will have to be very careful, we'll have to be alert, we'll have to analyze if something breaks, or if I find that my patients are not satisfied, I'll have to analyze, self-analysis to be done, and keep our temperament cool. In some cases, you will have to change yourself if necessary. Probably because throughout your life, you will have to maintain it. And if you cannot maintain it, it will be difficult and there will be problem. So in this, finally, I will tell you the story of an eagle. You know, the eagle, they survive for 70 years. But around the age of 40 years, their life will become miserable. Their wings become very heavy. Their claws also bend too much. The beak are also blunt. They cannot take prey. They cannot fly well. Even the dogs can chase them. Their life really become miserable. What they do? They go to any a deserted place or a hilltop where they spend about 180 days, about 6 months they spend. What they do, they take out the feather, they rub or the scratch with the claws within the stone to make it sharp, and they become lighter. And after 180 days, about 6 months, they come back to the jungle once again, and they once again they start their life, new life, and start catching fish, and that professionally become much more. So this hardship, 180 hardship for better survival and performance, it is important. So similarly in our life also, to maintain our professional excellence, we'll have to be always alert so that we can maintain that. Thank you very much. Nirmal, it is over.
Nirmal sir, yes, sir.
Sorry, I had a network problem. So anyway, I am on my mobile now. Thank you, Madanda, for such a nice lecture. So we learned a lot of things. Now I'll ask all the panelists to air their view. First, I'll invite Dr. P.V. Vijayaraghavan to speak what he wants the best way to communicate with patients. Vijayaraghavan, sir.
Yes, thank you to Professor Nirmal Mampatra. It was a very interesting talk, and I have had the chance to hear Dr. Rai in some of the conferences also on similar type of topics. And I just wanted to stress a lot of good points were brought out. Effective communication, when you look at, people should not forget only the oratorial speaking skills. As rightly told, listening skills are important. More importantly, the written skills, the ability to write a consult, the ability to refer a patient to another person in a written format, to precisely tell the condition of the patient are also important communication skills that a doctor should be concentrating upon. So this is an additional point that we must add on, that generally communication, people have understanding that it is the oratorial or the speaking skill that they concentrate. But the other thing is also important. I'm sure Dr. Rai will agree with me.
I fully agree. And initially, I started with the saying that it is only the office visit, but there are other aspects: how to refer, how to in indoor situation, in OT situation, how to communicate, and death news, how to report. These are all things that has a separate community. It will be very lengthy. Otherwise, I could have covered it.
Absolutely, sir. I agree. And the additional information that I wanted to give you was, I'm sure many of us are now practicing since 2019, the new competency-based curriculum for the MBBS students. Now it has got what is called the ATCOM module, which is attitude, ethics, and communication. And the communication skill is almost sort of done in about 4 or 5 modules throughout the 5 years of their training. And there are OSCE type of situations that are created. And I am also of the opinion that every medical college, rather than calling for many of these old animal labs and things like that, there should be a communication skills lab created in every single medical college. So this is need of the hour, where students can actually go and practice on standardized patients, many of the things that we have talked about. So that is practically another point that will improve the communication skill very effectively. And you all should know that the international patient safety goals, when you talk about the second important goal is the effective communication. Second important goal is effective communication. So if there is a lack of effective communication, there can be a lot of problems. As very nicely brought out by Dr. Rai, that many litigations happen, and if you analyze them, it is purely because of lack of communication. Because the doctor has not explained something properly and the patient has misunderstood, and so they start complaining and they go for litigation. These are some of the points that I just wanted to add, Dr. Nirmal.
Now I invite Dr. Sanjay Das to tell few things from his experience.
It was a very nice presentation. I've only heard before in Agartala, but Professor Rai has told now so nicely and so simplified manner. With his permission, can I add two things, Dr. Roy?
Yeah, please.
One thing I will tell that while conversation or while communicating with a patient, particularly the layman or the village people, let us not use medical language or medical jargons. That's a very important point. They don't understand anything. If you tell your hemoglobin is low, if you tell your tibia is broken, why you have to go undergo a surgery like interlocking nailing, so they will not understand nothing. So that we should not use. We should use a layman term as far as simple possible they can understand. Second point I will add: ask open-ended question. Let not told the answer with yes or no. The patient should not answer with your question yes or no. You tell how the pain started. How the pain started in your knee. Is the swelling fast or the pain fast? Like that way. This is another thing I wanted to add. Then always give a chance at the last, when the conversation is over, you are going to close or you are ending with the patient. Always ask the patient, have you got any question or any doubt you can ask me? I can clarify your doubt. That is the last thing you can ask the patient, and you're very much satisfied that doctor is taking care of you. And last but not the least, you have already told that if a elderly patient that will be told that if that patient with a geriatric problem or a older patient comes, at that moment it is better to call a family member, or if there is a disoriented patient or a
Dr. Ebnezer will
yes, that will be
that. Okay.
That I know. That just I am adding that we have to call a family member in that.
Really,
thank you.
Sanjay,
Thank you,
now
Dr.
I
Rai.
invite
what the language most preferred should be the in his own language, I mean, in any way, and with the signpost, with the bones, with the models, make them understand. And lastly, Sanjay, you have what you have said that lastly, patient we should ask the patient, is there any other question? Do you have any other question?
Yes,
That
yes.
that is very, very important.
Very important. And he feels satisfied.
And when you are allowed to patient when the patient is waiting for you, suppose you have asked the patient to for an X-ray. So why you are waiting, that should be clear to the patient, isn't it? I have seen it in USA on one hospital. My grandson was admitted for some reasons, and they did some tests, and it is written why you are waiting. Why 2.5 hours is people have to wait. That should be explained.
Well, I want Swarnendu to tell few words before we invite Dr. Ebnezer. Swarnendu.
Yes. I think Professor Rai has already been covered. What is the basic?
Video start ಮಾಡಿಲ್ಲ. Video start ಮಾಡಲಿಲ್ಲ ಕಾಣ್ತಿರುತ್ತಾ? Start video ಮಾಡಿಲ್ಲ ಇನ್ನು.
Well, we have one important question from one of our esteemed members, Dr. Chaudhary. Dr. Ray, can you tell how to counsel about financial implications with patients? That is most often very unpalatable, I mean.
That we honestly, we should disclose that the financial things, that for your treatment, this should be the expenditure, that should be the charges and all. We should be very honest. Otherwise, nowadays, you see, if you conceal, hide something, then it will be difficult to manage later on.
Yes.
Okay,
What
we'll
I
have
feel.
other questions later. Now, as we know, elder people, they're a special breed. They are like small children. Sometimes it is very difficult to counsel them and take questions from them and consult with them. So now now I invite Dr. John Ebenezer to give his skill in these aspects, after which we'll take whatever questions possible from the audience and also from the panels. Dr. Ebenezer,
Thank
please.
you. Thank you, Dr. Nirmal. Can you see my slide, Dr. Nirmal?
Yeah, we can see and hear you
Yeah,
also.
okay. So, I have stopped the video because of the bandwidth, So I'll be just, on the audio now. So thank you very much first for inviting me. It's a pleasure to be associated with your program. That too is for postgraduate students. And it's very important that these kind of programs are done to these young, budding orthopedic surgeons. So, and I enjoyed the talk of Dr. Ray. He covered a vast, aspect of communication. What is the importance of communication and how we are lacking in these communication skills. And that is the main cause of our problems. What is happening to the medical fraternity all over the country. So it's very important that, you select topics like this. Communication skills. We are all focusing on surgical skills. We are focusing on diagnostic skills, treatment skills, but hardly we communicate. So I think it is a very, very relevant subject what has been chosen, and I'm very happy to be part of it. And my expertise or my talk is now restricted to the geriatric orthopedic patients, whereas the general communication skills with the patients has been covered extensively and very well by Dr. Ray. So with that, I would like to go ahead, and you have introduced me. I think I will just skip this slide. Go ahead with the next. So let us analyze before we learn how to deal with the senior citizens. Let us now see what actually we are doing with senior citizens. Then we will see what should be the ideal thing we should be doing. How much time do we spend in our consultation rooms with senior citizens? For example, there is a patient who comes to us with knee pain. What do? We look at the knees. Hardly we look at the patients. And then we order an X-ray. And once the X-ray arrives, we say that, okay, now we need to undergo total knee replacement. That's all what we're going to speak to a patient. Suppose if the patient comes to us with back pain and neck pain, we order an MRI. And then once the MRI comes, we order a disc surgery. In a corporate hospital, who is one of my very close orthopedic surgeon friend, a patient came to me for a second opinion, and his complaint was, sir, I had gone to this very famous spine surgeon in a corporate hospital. When I went to him with the complaints of back pain, he was seeing his mobile. He didn't even lift his head and look at me. He just asked, what's the problem? And then I said, back pain. Then he scribbled investigation and asked me to get an MRI done. And then he continued browsing his WhatsApp. Then I went and got the MRI done. And after some 1 hour, 1.5 hours, I came back with the report. And then he saw the film and then said, you need to get admitted and undergo surgery. That's all. Over. So I was terribly disappointed, sir, because I didn't know what's my problem. And he didn't speak anything else. So I had to now come to you for a second opinion. Then there is one more very famous surgeon in Bangalore, very famous. He's always, his consultations are 150, 200 patients per day. It's teeming with patients. So he is always only 3 sentences he speaks to the patient. 1 line diagnosis he gives. Then he says 1 line treatment. And then if the patient asks any questions, he will just ring the bell and say, next patient, please. So that is how one of our senior doctors to do. So with heavy rush in the OPDs, hardly any times with the patient. more or less, this is how we are treating the senior citizens. Geriatric population is no longer small. It's big population. It's about 8 to 13% of the population is now comprising of geriatric people. You all know why, because our lifespan has gone up. It is now beyond 70. And the geriatric orthopedic problems are also definitely increasing because the lifespan increases. Now look at these geriatric patients. They have so many issues like knee pain, back pain, neck pain, frozen shoulder, and mechanical disorders like listhesis and osteoporosis. Not one, they have multiple issues. Except in a hip fracture, in geriatric orthopedics is not possible with the routine approach what we have been taught, like taking history, examination, investigations. And we are not able to come to a conclusion in a geriatric orthopedic patients. But in a case of a hip fracture, yes, we can make a diagnosis quickly and we can tell the treatment quickly. So you have got a hip fracture, it's intracapsular, extracapsular. Well, you need to undergo hemi replacement, arthroplasty, or a fixation. Done with. But geriatric orthopedic patients are not just about hip fractures. They are much more than that. And we need to have an approach which is totally different, not just an examination. Why? Why is that so? Because the geriatric orthopedic patient is battling with 10 peculiar challenges, and wherein the communication skill of a surgeon is very important in overcoming these geriatric peculiar challenges. What are those challenges? The comorbid conditions. You can see that there is a big challenge what poses in a geriatric orthopedic patient. It could be diabetes, hypertension, heart disease, obesity, you name it, patient has it. Secondly, co-musculoskeletal problems. Patient is not coming, if the patient has got knee pain, it is not just isolated knee pain. He will have neck pain also, back pain also, heel pain also. So many chronic orthopedic problems in elderly hunted together. And then co-physical issues, like patient has got a poor eyesight, poor hearing, the balance coordination is weak, and his mental conditions. He is battling with depression, dejection, anxiety, boredom, irritability, and emotional issues. Patient is emotionally unstable because of so many problems like maybe desertion in the family, separation, and loss of the spouse, etc. And social issues like patient has retired from job, he is not having his company now, he doesn't have his friends around, he is confined to his house, to his room, and especially in a situation like this pandemic, they hardly get out. So you can imagine what happens to their social life. And there could be bereavements, there could be loss of spouse. So that is a big setback for a geriatric person. His spouse with whom he has spent 30, 40 years of his life suddenly leaves, and now he is faced with a very terrible loneliness. And then the financial issues. Life is in a mess. Financial life is in a mess because all the savings gone, all the money spent on children, and now he doesn't have enough money to take care of himself. And if he falls sick and if he visits a hospital, then he cannot afford the treatment because of the financial problems. And the government, the insurance companies, cold shoulder a geriatric orthopedic patient above 75 years. Most of the insurance companies do not cover these geriatric orthopedic patients, and they are left to fend themselves, and that causes enormous stress on them. So all these peculiar challenges bring enormous stress on these geriatric patients, and they would be crumbling with the stress because of so many issues. Now, many or their house, so many other issues, and they have found themselves in old age homes. So a geriatric orthopedic patient now suffers as a whole, like he has physical issues, mental issues, social issues, and emotional issues. And there is a lot of fear about drugs, about the drug therapies. They are, they are susceptible to damage to the, systems like GI tract, kidney, liver. So they are scared to take medicines, and they are very much scared of this, advanced surgical procedures which are offered to them routinely in most of the centers, like knee replacement, disc replacement, all this. So all this fear, is lurking in them. So these insecurities, then all these worries, all these fears, with this, a patient comes to us. And we have got hardly any time to look into the problems of these patients. And then we just tell them one-line diagnosis, one-line treatment, and try to, see that they are taken, to the treatment table or surgical table, like that. So we need to learn how to dispel these insecurities in a geriatric patient. What has come to us is a patient. It is not just a bone, it is not just a joint, it is not just a spine who has come to us. He has come as a whole, and a geriatric patient is harboring so many insecurities in his mind. And with that, he has come. He is trembling in front of a doctor. He's waiting what the doctor is going to tell them, because he knows that his situation is bad. He is having so many back issues, knee issues, and he is now worried that what the doctor is going to tell. And with that he comes. So a victim of geriatric orthopedic problem is like an attack not from a single dog, but multiple dogs or a pack of wolves. And these wolves are nothing but the comorbidities and the musculoskeletal conditions which pounce on these geriatric patients. And they are here in front of us in our consultation room, sitting in front of us. And we are now in a position to, allay their fears. But instead, what we do is, because of our approach, we make their problems worsen. And it is like saying that they are having been like a 10-headed Ravana. These 10 heads are all these morbidities and all these co-muscular problems. And our approach is not going to solve it. So if I say just undergo a knee replacement, or if I say undergo a disc surgery, or if I say undergo a hip surgery, do we think we are going to solve the problem what a geriatric orthopedic patient has? No, because the problems are too many, which I enumerated in front of you. So we need communication skills to arrive at a proper diagnosis in a geriatric orthopedic patients. Otherwise, we will not be doing justice to them. What is that a geriatric orthopedic patient is looking from us or seeking from us? He wants empathy, not sympathy. He wants reassurance that everything is fine with them. Everything is fine, so he would get back to his normal health. That's what he wants to listen from a surgeon. And he would definitely want to improve his quality of life so that he's not a burden on his children or on anyone. That is what he's looking at us. And communication, why it is very important in geriatric patients? Because diagnosis is not possible in 1 or 2 minutes of consultation, what we normally do. We need to look at our patients and not just see them. What we do is we just see the patient. We are not looking at them. Looking means you have to look properly. And once you see the face of the patient, then you will know what is actually within the that person. Face is the index of the heart. So you will know by looking the anxiety, the fear, is everything seen in the eyes. So we should learn to look at the patient first properly. We hardly look at the patient. We look at the mobile, we look at the laptop, and we look at the X-ray, we look at the MRI, but we fail to look at the patients. So that is one criminal thing what we do. And we need to listen to the patient properly, not just hear the patient. It's not just the word, the sound that is being produced. Patient is telling us something, and listening is an art. It is different from hearing. Hearing is different, listening is different. A good communicator is one who knows how to listen. Good communicator is not the one who speaks. Means good talking skill. No, means listening. It is all about listening. The way you listen is very important. And a person or a doctor who listens well, to a patient is a good communicator, not the one who speaks more. So effective communication skills will comprise the following. What is that? The empathy towards the patient, one. Second, the human approach. We need to develop the human approach. We need to talk. We need to
There may be a net
corona,
problem.
maybe
Okay.
we are. Oh. Yeah, can you hear me?
Yes, yes, yes.
Now,
Okay, so the communication skills, not empathy, the human approach. We need to approach with the talk, listen, touch, and hug. Then we need performance, good performance to make to fill up this performance, not just look at the patient and say, okay, this is the diagnosis, go. No. What this performance do is, I'll show you the performance later. It helps you to interact with the patients. When you're filling up the performance, you talk to your patient well. So you elicit all the history from them, and it will help you to arrive at a comprehensive diagnosis. It is not just hip fracture. It is not just arthritis. You'll come to a proper comprehensive diagnosis. Here is an elderly patient, 65 years old. He has got bilateral OA knees with comorbidities like diabetes, hypertension, IHT. He has got co-musculoskeletal conditions. He suffers from depression, anxiety, and he has taken the treatment earlier, and now he has come to this. This is the comprehensive diagnosis which you will arrive at if you use the performance. And most importantly, the fourth approach is the counseling and the health education, which will build the trust and rapport with your patients. If you counsel and if you educate, you become a friend to your patients. So we need to replace our skeleton-based approach to a human-based approach. We need to replace sympathy with empathy. And a skeleton-based approach, what we are practicing now, has to give way to a human-based approach. And I said, what is this human-based approach? These four effective communication skills. What is talking skill, listening skill, and touching skill, and embracing skills. The talking skill is extremely important. We need to talk. Tongue is mightier than a sword. Everything is in the talk. You can make or break a relation with a talk. And why do we think we get into problem? Why do you think patients assault us? Why do you think they break the furniture? Why do you think they'll stone us? Because we are so callous in talking. We are not, we are very rude, arrogant, and we don't have patience to talk. So that is where the problem starts. So we should know how to talk smoothly, talk caringly, talk lovingly. Everything is in the talk. Patient will start relating to you better. A sweet talking doctor is more acceptable than a more skillful doctor. You may be a great surgeon, but if you don't know how to talk, they are not going to accept you. Second, listen. Listen, understand, act. This is what is very important. Patients are talking, but I am not listening. So we should learn the art for effective communication, listening skills. Very, very important. We have to be attentive. We should be genuinely interested in our patients. Do not believe whatever is being told by the patient, because patient may be cooking up stories and patient may not tell you so many things, and do not ignore that what is not being told. Learn to discriminate between what is real and malignant. For example, an elderly lady comes to outpatient, to so many times I've experienced, sir, I've got back pain, I've got knee pain, nothing is helping me. I've gone to so many doctors, I've got so many investigations done, and I've taken so many medicines, sir, I'm not getting all right. Then you look at the X-ray is fine. You look at the lab report is fine. Then what is the patient telling? The patient is telling so many, and by the side of the patient, the son or the daughter or the son-in-law or the daughter-in-law is sitting. They're all fully anxious and looking at me. Then, now I know that what this patient is telling is not matching with the symptoms, objective analysis, what I'm doing. So I now know that there is an issue which is not, which is something different. Then I just ask the attendants to leave the room. Then I ask the patient, you actually tell me what is your problem. Then that lady will come out. Sir, I don't have any problem. I got problem with my daughter-in-law. She makes me work a lot at home. I have to cook. I have to stand for a long time. I have to take care of the grandchildren, and I have to do so much of work. I am not finding any rest, sir. That is why I'm telling I have back pain. I'm having knee pain. I'm having neck pain. I want them to take me to the hospital so that I get some rest. This is what the patient is telling. So this can be picked up by your good listening skill, because now that by listening properly, the issue is with something else, not with the disease. And some things patient may not tell you, and don't ignore that. And you should know whether the complaints are real or malignant. All this can be done if you have good listening skills. The whole body listening is extremely important, not your whole body. You listen with the whole body, not just with your ears. What happens if you listen well? If you listen, the benefits of good listening, patient will like you. The moment you listen, 50% of the patient's problem is solved then and there without even you prescribing a single tablet. If you listen to what the patient is telling, patient feels, because patient is carrying a lot of garbage in the head. They want to dump it on somebody. They want to dump it on somebody so that they are freed of their burden. And a doctor is one person who can absorb that garbage. The moment you listen to the patient now starts feeling better. People like, if you listen to them, the relationship improves. There will be greater clarity in your relation that's happened. So that is the benefit of listening. For that, you have to listen with the eyes, you have to listen with the ears, listen with the mouth, listen with your hand, listen with the whole body. That means your completely whole body has turned into ear. You are talking to your patient. That is the art what we need to develop. We spend fellowships, we go to fellowships, we go to so many programs, so many CMEs, so many conferences, hone our skills, surgical skills, but we never believe that these are some of the skills which are extremely important, and we need to spend time to learn this skill. It's not just going to come like that. How to listen is an art. Any Tom, Dick, and Harry cannot listen. We need to learn that art. The touch so much, soothing to the patient. The magic of touch. No, it heals. If you touch, the moment you embrace a senior citizen, your grandmother, your father, your mother, if you just hug them, you see the relaxation they have. The pain is reduced, the anxiety is reduced, and it stimulates the body's healing mechanism. So learn the habit, this habit. Now the corona is there. Maybe you may not be able to do it, but sooner or later the corona will disappear. You can still go ahead and do this to your patients, because that will establish a rapport with them. And the benefits of hug: instant oxytocin release, serotonin release, clinically proven. Patients feel better. So this human communication skills, what I call, what is the advantage in geriatric orthopedic patients? It helps develop a rapport with your patient. It soothes the nerves of the patient. It allays the tension and fear in them. Now, the compliance improves. Patient becomes more receptive to what you're going to tell them, and your treatment is going to become effective. It helps develop a very healthy bond and then reduce the stress in the patient. And litigation rate also drops significantly, because nobody is going to sue a doctor who is like a family member. Earlier, we had the concept of family doctors. Why there were no cases against family doctors? Because he was one with the family. He used to come to their house, sit with them, sit in front of their bed or in front of the table, have a cup of tea with them, talk all, extra, like how's your family, how's your health, how's your business, how's your farm, and then lastly is to come towards the illness. So that kind of family doctors, that they were never sued. Now it is all this suing business is happening now, because we hardly have got time for our doctors. So that was the first communication skills. Using your human approach, you learn that, you will definitely be on the plus side. Now this proformas, there are 6 proformas which I use in my patients, which will help you the communication skills, as you'll get to talk to the patients and know them better, and it will help you to make the proper diagnosis. What we normally do is we hit this investigation button first. No, take this proformas. Here, you got history, you got demography, you got associated musculoskeletal condition, associated comorbidities. Enter all one by one. Or if you are very busy, ask a junior doctor to do this for you. And then this demographic data, clinical data, as you start taking this in detail, the diagnosis starts becoming clearer. The treatment choices will come up to you in a much clearer situation. Like the patient has got arthritis, and with the same, the same patient also has got OA of the hip. Patient has got OA of the spine, and the patient is diabetic, comorbid. Now. So what are the treatment choices you're going to make? You're not going to just say replace the knees. You can now say that no, along with the replacement, you need this, you need that, you need physiotherapy for the back, and you need diabetes treatment, you need obesity treatment, you need to reduce your weight. So the treatment choices, selection, everything improves when you start filling the proforma, because you have made a comprehensive diagnosis. You're not rushing. What is the disability in the back? What is the disability? If the patient doesn't have much disability, what is the point in offering, very major surgeries for such patients? They
There's no sound, Dr. John.
in the house, they want to go to the temples, they can manage their lives. If the disability is less, you can always give them a much, option which is acceptable to them. Then fill up this stress, scores. Find out how much is the stress in this person. Once you fill up this stress scores, you know where the patient is, whether depressed, whether anxiety, all this you know. Then lifestyle. Take the, fill up this lifestyle questionnaire. You ask what time the patient gets up, what is the food, and what is the exercise, and what is the habit, cigarette smoking, alcohol, all this lifestyle. So once you know the lifestyle of the person, you can advise better. And all that. So these, proformas will now help you to make a whole body diagnosis. And now your communication skill has, convinced the patient that you're genuinely interested in them. You're looking at them, you're asking questions, you're making them fill up the proformas, you're not rushing through the diagnosis. Then comes the convincing skills. You need to convince, that's all. If you convince the patient, they're ready to die for you. The great leaders, they could convince anybody to do anything. How do you think that, all these terrorists are convinced to kill, so many people all across the globe? Why? Because the convincing skill of the leaders. They convince them that if you bomb this hotel, if you bomb this aeroplane, you will reach heaven straight. They convince. So once you convince, they are ready to, even commit suicide. So if you can convince the geriatric patient, well, this is in the best interest of you, then you take it from me. They will accept your suggestion and they are ready to buy the surgery. You struggle to sell the surgery. Don't sell the surgery. Tell the patient all the options. Tell the patient what is the problem, what they have. They will themselves come out saying that, okay, doctor, please go ahead and operate on me. So, and always give them the benefit of judicious drug therapies. Give them the benefit of non-operative therapies like good physiotherapy, good exercise therapy, yoga-based therapies, walking, jogging, and all this mind-body exercise. And tell them about what to eat, what not to eat, how to eat, when to eat. Tell them the supportive therapies like canes, belt, all that. Tell them about the reversal therapy. Ask them to stop alcohol, stop smoking, stop the stress. Then if you stop all this, the whole thing gets reversed. You'll feel all right. And then you tell that you're communicating with various specialists because a geriatric patient has got so many issues. So you are liaising with everybody, physicians, psychiatrists, psychologists, therapists, endocrinologists. So the patient is very much convinced that you are a team man. So you are not only going to wield the knife on him, you are definitely going to see him as a whole and treat him. So once he knows all this, when you tell surgery, he accepts because he knows that this doctor has given me all options and he has got the best interest of me in his mind. So the other important communication skill apart from this human qualities, proformas, is the counseling and health education. You need to counsel them along with their spouses, with their children. You make them sit in front of them. You don't just talk to the senior citizen who has come to you as a patient. Talk to the spouse about how their body is made up of, musculoskeletal structure. Tell them the mechanics. Tell them the function of the joints. Tell them the function of the back. Then tell them the importance of good posture. Tell them the importance of lifestyle. And tell them the importance of good habits. Tell them the importance of good diet. Tell them the importance of yoga, tai chi, all this. And then when you tell all this, when you educate them, they become closer to you. Now they are ready to listen to you. And get out of your consultation chambers once in a while. That's what I am telling is what I am doing. So what I do is I go for various outreach programs. I go and talk to the senior citizens. I do a PowerPoint presentation. I tell them about the needs. I tell them about the preventive steps, what they need to take. I tell them the lifestyle so that they are very happy. Here is one surgeon who is telling us how to take care of the knees. He tells how to preserve the knees. He's not telling he's going to remove the knees. See, the rapport what you develop with them is tremendous. They develop the trust in you that he is a well-meaning doctor. So get out. Then massive public health drives I do. I go around teaching them how to do exercise. I will not just tell them, I just do this exercise, how to do quadriceps exercise, how to do back stretching exercise, how to do neck stretching exercise, how to do general yoga. I teach them myself so that they learn. Then the rural health awareness. Go to the rural health, go to talk to them, tell them that your health is in your hand. Now you're as good as your body. So learn to take care of your body. The health is within you, and I can only suggest, but you are the one who should implement all this. So this Save Your Knees campaign, which I took around, was attended by scores of people, because they were all very happy that we are getting something new, something different. Actually, I'm doing what a doctor is meant to do. I'm not doing anything extra. This is what we are meant to do. That is why we have become doctors. We are not become doctors to just operate, just fix the fracture, replace the joint, and hope that everything will come back to normal. No, it's not going to happen. If you just fix the bone, I have seen so many patients of mine who came to me for second opinion, knee replacement done, they have gone on a wheelchair. Why? Because the patient had got a OA hip also. The surgeon did not look at the hip joint at all. He just replaced the knee. And once the knee was replaced, when the patient was asked to move, he could not move because there is a massive arthritis of the hip. Why did this happen? Because we just replaced the joint. No, that approach has to go. We have to see the patient totally, and then only offer the treatment. Then nothing will happen automatically. We have to work for this. We need to learn this holistic approach, and this is what is holistic orthopedics or geriatric orthopedic patient. You're treating them as a whole, not in isolation. What's my take-home message to you all? Geriatric orthopedic patients have special concerns, have multiple issues. It is not like in adults where quick examination and treatment is offered. An adult comes, he has got a problem like a tennis elbow or say a repeated stress injury or a fracture. It's a quick examination, quick treatment. A fracture, we say X-ray, come on, surgery or plaster, over. But that's not going to happen in a geriatric orthopedic patient because he's housing many problems which I've discussed with you now. So we need to apply the Mahatma Gandhi principle. We need to see more. God has given 2 eyes. So see more, listen more, and speak less. That's the attitude what we should have towards a geriatric orthopedic person. Communication skill, please remember, is all about listening. It's not about talking. This is a dying art. It's a dead art. This art we don't have. We don't listen. Hardly we listen. I have gone to this neuro center like Nimans, Kidwai, the junior doctors, they hardly listen to what even a senior doctor like me is telling. They will just not lift the head and see also, because they're so busy in writing case papers, writing the, typing the this, that, they don't talk. So it's a dying art. It's dead art. To take it from me, you may be a great surgeon, great doctor, but if you don't listen to your patient, they'll not accept you at all. So we need to replace sympathy, empathy, and give adequate time to geriatric patients. We'll need to learn how to dispel the fear and generate confidence in them. The present pandemic, this corona has worsened their situation. They are homebound. Their comorbidities have gone up. Their, the NCDs, the non-communicable diseases have gone up because of the fear of corona. They are not going to the hospitals. So the diabetes has worsened. The BP has worsened. They are dying at home. They prefer to die at home, not come to the hospital. Things have become very bad. So we need to learn how to communicate, how to build that confidence. Now by virtual, by Facebook, WhatsApp, or by the meetings like this. And we need to explore all the possibilities available in treating a geriatric orthopedic patient. You should not give one-line diagnosis, one-line treatment. You have got arthritis, now you undergo surgery. No, we have to tell them all the possibilities, how much is going to help them. So this will dispel the fear of surgeries, and in very few cases where surgery becomes mandatory, patient is ready to accept you. And in one word, if I have to tell you, what should be your communication skill in a geriatric orthopedic patient? Well, in every geriatric orthopedic patient, please see them as your parents or as your grandparents. How would you treat your parent? This is how you would treat your patient. If your mother says, I'm having back pain, will you write an MRI to your mother and say, go and get a surgery done? Or if your grandparent comes to you with a problem, will you tell, okay, get this and get operated? No. You are full of empathy, you are full of love, you embrace them, you counsel them, you are the first person who will not tell surgery to them, to your mother, to your father. So treat your extended family. Treat the geriatric orthopedic patients as your extended family, and take it from me, you will not regret this approach at all. So your communication skills should reassure the patient, rejuvenate the patient, offer hope to the patient, and not push them into despair. This is what we need to do. Thank you very much. Thanks for the invite. I hope, if there are any questions around, I would definitely go ahead and take. And it was a pleasure interacting with you all. And thank you very much.
I believe there is a connection problem with Nirmal sir.
Hello?
Yeah, sir, I believe there is a connection lost by Nirmal sir.
Nirmal sir is not there?
Yeah, he is there. I believe there is a lot of loss of connection. We'll join again.
Yeah. That happens. I had lost the connection a couple of times.
Yeah.
Not an issue.
I invite Hiravan sir to tell his opinion on how to approach a geriatric person, and also anything he wants to add to Dr. John's lecture.
Excellent presentation, Dr. John. I congratulate you. A lot of good information has come. I quite agree with most of the observations that you have made. One important thing that we need to realize, particularly while treating the elderly patients, sometimes they are hard of hearing, sometimes they cannot see. So these are disabilities that they carry. And as a doctor, you should not think that your problem is orthopedic problem. So you don't have to give consideration for that and start speaking only to the relative. He gets, generally the elderly person wants to have the doctor hear him. And so he would like to take his own time. Generally, the time required for a geriatric patient will be much longer than when you see a diagnosis for a younger person, because that may be spot diagnosis. But here, spot diagnosis many times doesn't work. You are absolutely right that a lot of problems are multi. That is, it's not a single problem. There will be other problems, and you have to very clearly explain to the patient on the outcome that by doing something, it may just relieve that problem of that particular joint or that particular region, but it may not completely solve the problem fully. As you rightly said, many times they are under depression. And in depression, some of these patients can do two things. One is they are overactive, or other thing is they are extremely silent. They will not just open out. So there must be sufficient time that you should provide to get the complete information. As much as in a pediatric child doesn't talk, similarly in an elderly patient also you have to give sufficient time. One of the important characteristics of professionalism, which is also the topic of the day today, is actually developing the effective communication skills, whether it is a pediatric child or it is the effective communication of any type of patient that may report to you, or the elderly patient. The techniques are slightly different, but we have to learn this art. And my important observation which I made in all years of my practice is, generally, as you say, at the back of your mind, there must be some reflection and observation that must be going on in your mind as you are doing this. As rightly told, we have diagnosed any number of Parkinson's disease, even as an orthopedic specialist, when some of these elderly patients come. Slight, tremors or slight movements can all be observed. They may not tell about it. And they may even, on forcing and asking, they may come out and tell certain issues. So actually, as rightly told, the surgeon who actually can communicate well is the ideal good surgeon. The person who just keeps operating maybe all right in terms of getting some outcomes radiologically or to the patient in some way, but in the long run, it does not help. So I just wanted to add these points as important points, because in professionalism, one of the professional characteristics that a doctor should exhibit is an appropriate communication. I have seen some cardiologists, as rightly told by Ebenezer, who in a dark room, they will be just sitting and keeping on writing without talking one word to the patient. That is not usually very good. Thanks, Dr. Nirmal, for this opportunity.
Thank you,
Thank you,
sir.
Dr. Raghavan.
I invite Dr. Sanjay Das to tell you his observations on these things.
Yes, Professor Avenger has nicely presented so elaborately and in a simplified manner. We appreciate your talk. Everybody will
Thank you,
also
sir.
appreciate.
Thank you, sir.
And some points just I'll want to clarify from you that 6 performers you have shown. Is
Yeah.
it possible to fill up in the OPD?
Yes, yes. Now, what happens is, when the patient comes to me, in the reception itself, they'll have filled up the address, all those the basic details, and the general examination like the blood pressure, the pulse, everything is done. So when they come to me, I have to just ask specific questions and fill it up fast. And the history also is taken outside, like whether the patient is diabetic, hypertensive, and all this treatment. It's all ticked up. It's all filled up in that form. So one that comes to me with that form, everything is there. I just have to fine tune it a bit. That's all. And then I know.
Oh, everything is pre-filled, you mean to say?
And with practice, the whole thing will speed up. Earlier, it will take some time to do all this, but once you start doing it, I have found that I will not be taking more than 10 minutes of the time to do all this. Even the examination, everything becomes so simple.
Yeah,
so it's all a matter of practice.
Yeah. And
Dr. Nirmal, I just wanted to add in this point, while these proformas are very good and they can be filled by anybody and they can come, but when they consult you, it may be worthwhile for you to tell the patient, I understand you've been a diabetic for 20 years, something like that, realizing that otherwise they think that the main doctor has not known his problems. So it is better, going through that, you just summarize in 2 lines or 1 line. Yeah.
Yes, sir. Yes, sir. What you say is right, sir.
So, Nando, if you want to add anything.
No, I think the main thing is that by around 19, to be very specific, from 1991, the health authority around the world, they understood that the communication skills should be inculcated in the medical stream. So it is not very old teaching purpose. It is going throughout the world. It is hardly for 30 years only. This is in the agenda of the communication skill in the medical stream. And there are, if you go ahead with suppose if the junior, the PGTs, they are listening to it, there are 4 sort of communications that is between the doctor and the patient. One is the default. That means he has some problem, he has come to a doctor. Second one is the like a parent sort of thing. Whatever the doctor will take, he will think the doctor is a god. And third one is the consumer sort of thing, which is now prevailing in the market. That means they are paying you the money, they deserve the best from you. And fourth one is the mutual relationship. So probably if you develop the communication skill, then only the last one, which I told you, that is mutual understanding, that means they are not believing you like a god. Still they will believe you at that extent. They will, because whenever you do surgery or you do some medical treatment, so you have to explain all the probable things and they will believe you that whatever you are telling, you are doing the best for him. So unless you give ample time and your attitude, whatever I told Professor Rai, your attitude should be like you are listening, you are caring. Otherwise, whatever best possible medicine you write, still they won't be happy because of your attitude. So your attitude, your soft spokenness, and everything, how you are dressed up, whether you are standing, sitting, like a mood of picking up a phone, this should not be during your consultation. You should be completely recharged from the whole world. And when you are seeing the patient, patient is the God to you. And if you remember that the patient is your best and nearest relative, you will never make a bad decision. You will never do an unnecessary surgery. So I tell all my PGTs that whenever you see an old guy, see that you are treating your own grandma or grandpa, or your suppose young guy, your brother.
Like
Or,
Dr. John told. Yeah, that's very right.
yeah, yeah.
Yeah,
So
so, yeah.
Well,
never take the patient like your patient. It has to be thought like you're my relative. Then only your decision will be 100% correct, and your skill will automatically develop and come. It cannot be taught.
okay, I'll ask Professor Rai to tell something, his opinion regarding all these things.
Whatever, thank you, Nirmal. Whatever discussion we had in this session, that one thing we all appreciate, we must be very soft-spoken, we must be very polite, and we must be very honest. And nowadays, everything should be explained very honestly. Otherwise, you will be in trouble. That is the main thing, I think so. And listening of the patient, what Dr. John was saying, and I also, and everybody is present here will say that listening to the patient. And it is a great saying of the William Osler that listen first, listen second, and listening, if you listen to the patient, that they might tell you the diagnosis. That means listening is very, very important. I think so.
I
Well,
with the permission of Professor Mohapatra, just want to just add one line. I will take hardly 30 seconds. Probably we
sure.
forgot about the whenever we are listening to Professor Rai's lecture, even my dear friend John's lecture. Thing is that this is for the juniors. Whenever there is a complication of your surgery or any treatment, please explain and admit that. Because if you just want to hide that, don't admit that, and you are reluctant that you are not, you are just careless about the complication, and you think that I am the best surgeon in the world, no complication will happen to me. So please don't avoid, don't hide, explain that complication can happen to anybody.
Yeah.
This is the part of the story. If you just avoid, there will be problem. And if you just tell sorry and explain them, rather than going 100 times or 10 times to the high court or dragging between the high court and lower court. So try to explain that, yeah, this is a known complication, this is the percentage, this has happened to you.
Well,
Dr. Swarnendu, can
we
I
have
add?
kept our next
Dr.
topic
Nirmal.
on this. How
Swarnendu,
to
I
bring
want to add.
Hello.
Okay.
Swarnendu, I want to
Dr.
add.
Nirmal.
Swarnendu,
Yes.
can I add something for you?
Dr. Nirmal.
Well,
Yes,
I was
suggest.
telling, actually, we have kept that for the next webinar. We have kept how to break bad news and how to tell sympathetically or empathically how to disclose the news of disaster like death. We have that kept that for subsequent webinars.
That is a big
Dr.
topic.
Nirmal.
This
Yes.
Dr. Nirmal.
part is
Sir?
also the part of the
I want to add one thing.
Yes, Sir John, please.
Swarnendu said, when there is a death or when there is a complication, it is the senior doctor who has to come out and talk to the patients.
Yes.
Not
Yes,
the
yes.
junior doctors. What they
That is
do, what I have
paramount.
seen is, suppose if the patient is dead or if there is a complication, the senior doctor disappears. He pushes the residents, registrars.
Yeah.
They go and break the news in such a horrible manner. Already there is a problem, and there is a very, how to say, a situation which will go out of control.
That's why Dr. John, I told you that.
Yes.
Dr. John, I told this is the avoiding attitude. This
Yes.
attitude, this avoiding attitude, if you do that, then there will be litigation.
Yeah, that the junior
Really.
doctors, they don't know how to talk. So
Avoid-
a senior doctor, if he comes forward,
And
I think
Can I
that
interrupt 1 minute?
You
1
must
minute.
be very clear
Swarnendu.
from the beginning. Very clear from the beginning.
yes,
That might happen. That complication might arise. And,
yes,
But usually it does not happen. Certain
Yes.
percentage, then they will be convinced. Yes,
Yes.
then it is my luck. It may come, it may not.
Yeah.
Sir, can I add
Yeah,
one thing?
Dr.
We hide
Nirmal,
anything, then it problem will arise later.
Nirmal, can I add one thing?
Sure.
Yes, Swarnendu, you have told that it is 100% correct that you disclose the complications. But what is the time to disclose? That's very important. I have heard from Professor Tana. He told that something happens or some complication develop in OT. Never tell same day. Wait for 2 days because the patient is already in agony, already in pain, already in depressed, already shouting with pain. And at that time, you are giving another sad news. He will be irritated. All the family members will be irritated against the surgeon or over the surgeon. Wait for 1 day or 2 days. When the pain subsides, patient is calmed down, then you disclose your complication or in a better way.
Any
That's what
complication can happen during the, suppose you can there can be like radial nerve neuropraxia during the humeral plating. But the most important thing that I want to tell the juniors is nowadays your communication is equal to have the informed consent. Informed consent means all the 5-6 main common complications are being
that will be told from the
written.
earlier.
Then
From the
it
beginning
has to be written, and every page of that informed consent should be signed by the patient if the patient is adult, or else by two relatives. So this is the rule.
My point of telling is that not to disclose immediately after coming to OT. That gives more difficult situation. The patients will be angry and the attendants, the family members, everybody will be angry. Wait for 1 day, till next day when the pain subsides.
Well, Professor Raghavan, only last word from you. There you end up. It's already 2 hours.
Dr. Nirmal, thank you. I quite agree with Dr. Samantha in his that we should have used this informed consent also as an important communication skill that people should practice. And it has got almost 5-6 components that have to be filled up. What is the working diagnosis that you have in mind? What is the treatment proposed? What are the various complications that may occur as a result of this treatment? All these things, and also a little bit of cost towards the treatment. All these are included in an informed consent. And I remember still, I'm sure all of you remember Professor Sriram. I worked with him for a year for scoliosis surgery in every patient, that I could become a paraplegic or a quadriplegic. This used to be mentioned in the informed consent. So when you 1 or 2 patients may not get that surgery done, but when you are openly, transparently exposing such type of information to the patient, they are grateful. 99% nothing will happen, and that's another way of putting that in a joint replacement, the infection rate is above 1 in 500. You can say out of 500 patients, you could be 499. You could be 1 in 499. Such type of explanations give them, rather than telling 5% can happen, 20% can happen, and things like that. Thank you. Conversation.
There is one question, and Dr. Roy, you can tell how to handle media for exploiting the patient for a complication.
Can you repeat, please?
How to handle media for exploiting the patient for a complication.
Oh, yeah.
That is very common nowadays.
It is very difficult because, you know, the media has already in their the back of the mind, they will do something against the doctors. First thing.
Yes.
So they have already in their mind. So whatever you say, they will take it in otherwise. So thing is that you will be in a position that you tell the truth, only the truth. I did this, that was the complication, and that was told, it was in consent, and that has happened. And I'm trying to solve this problem to the best of my ability. That should be the approach, I think. So.
Nirmal sir, just 5 seconds I will take you from your permission.
Sure.
Just 5 seconds I will take. 5 things, juniors, please remember. 5 basic things, if you remember from today's webinar, you will be happy. One thing is communication. Second thing is documentation. Third thing is communication of documentation. And fourth one is documentation of communication. And fifth one is preservation of documentation. So if you follow these 5 principles, you safely can go home from today's webinar.
No, yeah, and that is very, very important for the legal issues as well. Legal
yes,
issues.
These are the 5 things. Last point is most important. preservation of your documentation.
Preservation of documents. Everything should be documented.
Well, I'll thank you, sir, for such a nice seminar. Now I'll hand over to the organizer. Before thanking, I must give special thanks to Saswat. He is our coordinator for all these things, and also Andrew. Andrew, now it is your mic. You can tell whatever you want for a few minutes, and then we
Thank you very much, sir. Nirmal sir, I would like to thank you once again for offering us this opportunity to manage such a nice session and a wonderful session. And of course, sir, it's my heartfelt and personal thanks to Dr. Saswat Samant also, who has been a pivot throughout all these scientific procedures, because without Dr. Saswat Samant, these programs would not have been possible. I believe, Nirmal sir, you will also agree with me. And of course, sir, I would like to thank all the faculties, Dr. John, Dr. Vijayaraghavan, Swarnendu sir, Sanjay sir, as well as Dr. Rai. So, sir, thank you very much. And I would like to hand over to Mr. Shishendu Mukherjee to say a few words before we would like to invite our Vice President.
Sir, thank you very much for a wonderful session, because this is also learning for us also, this communication session. So with that, I request our Vice President, Mr. Gautam Chakraborty, to give vote of thanks.
Thank you, Shishendu. Frankly, I'm speechless. At the moment I'm speechless, I'm a better communicator. What had been said by Dr. John, and I not only believe in that, I personally practice that. And all of you know that. Because when I tell all of you, because we are into the business of communication, because we are into sales and marketing. So it's a business of communication. And when we talk about communication, it is all about listening. The more you are a better listener, better you are a communicator. And data says that just by patient listening, 50% of the problems goes away. Whether it is a patient or it is a person who has come to you with a problem. So I strongly believe wonderful presentation, fiery presentation by Dr. John, amazing. It is all learning for all of us. Last 2 decades, I am attached with Dr. M.M. Roy. I know him since almost 20 years. And I have heard him talking on different topics on orthopedics. First time, sir, I'm listening to you talking on communication. Wonderful. And I strongly believe the point you have raised, that is the best point. At every level, you are handling patients or you are handling sales marketing, you have to be honest. And the moment as a leader, you are honest. As a doctor, you are honest. Everything falls in place.
Always, always.
Always. That is the best part. Again, I'm an amazing speech by Dr. M.M. Roy. Thank you so much, Dr. Saswat, for allowing us and partnering to this platform. Obviously, Dr. Nirmal, Professor Nirmal, you are amazingly, coordinated this entire show. Wonderful comments by Dr. Vijayaraghavan, very, very valid points. Dr. Sanjay Das, and of course, Dr. Samanta also, I am aware about him many years. And your 5 points, sir, I will now, keep it in my mind. Again, not to handle media, but to handle many of the factors in sales marketing.
And Mr. Gautam, you will be, and all Vijayaraghavan sir and everybody will be happy to know that I started my orthopedic journey from Odisha, and I passed from SCB Medical College. Sanjay sir, Nirmal sir, they are my teachers. And I was the member of Odisha Orthopedic Association. First orthopedic membership is from Odisha Orthopedic Association.
He is more of a Odisha Orthopedic Association member than most of our members.
Correct.
He is more involved with us.
You had a portfolio.
Dr. Nirmal.
Orthopedic
Dr. Nirmal.
Sir. Yes, sir. Hello, sir.
I wanted to apologize to you that I did not send my latest CV. Now I have been promoted to Vice Chancellor of our university from Director.
Oh my God.
Wonderful.
In your introduction.
Just
Congratulations.
Congrats, sir.
Congratulations, sir.
Wonderful moment to share, in fact.
Sir, we know you are a very academic. That's why I contacted you, sir. I know you since so long, and I have involved with you. I know you are always smiling like the Mona Lisa smile. You are never in a even when fighting elections or other things, you are never in a sorry mode. You are always happy. That's
This is a
I
good
admire
quality
about
of
you.
communication. This is a good quality of
This is good
doctor-patient
quality of
communication.
Yes.
Absolutely. Absolutely. So wonderful. Thank you so very much to all of you. And I'm really happy to say that, Andrew, you have really lucky to have this forum, because hardly this kind of forum is going to be available for pharma companies. And as WOCHAD, I can assure you that we always believe in such kind of academic forums where we want to be attached, and we promise on behalf of organization that not only today, tomorrow, for a day, I mean, coming whenever it is required, our assistance will be available for these kind of programs. So thank you very much from
Thank you.
Thank you,
Thank
Dr.
you.
Gauss.
Thank you.
Thank
Thank you
you.
Good
very
night.
much.
Good night,
Good
everybody.
night.
Sir,
Bye-bye.
be safe for the next till
Yeah,
next.
John, take care. Meeting after you for after long time. Thank
Yes,
you.
yes. I
Thank you,
remember
John.
Dr. John was with me in the Bhubaneswar conference, international conference, geriatric infant conference.
Yeah,
Dr. John,
geriatric meeting. Yeah.
geriatric,
Okay.
Dr. John was there all the time.
Take care.
Dr. Sarnendu.
Take care, sir.
Bye.
Bye.
Good night,
Good
everyone.
night. Good night.
Good night.
Thank you, sir.
Good night,
All
sir.
right, Madan da,
Good
bye.
night.
Madan da, bye.
Thank you. Good night.
Yeah, good night.